to the next segment, we have a presentation on evaluation of chest pain, and this will be taken by Dr. Iseko and Dr. Anya. Please kindly make them welcome.
All right, good afternoon. We are a little behind time. I want us to stand up for 1 minute, just not 1 minute, 10 seconds, stand up. Let us practice what we preach. Stand up, stretch. Now I want you to stand on your toes, up and down, up and down, so that we don't have DVT here, up and down. Now I want you to take a very deep breath in, hold it, and out. Now the next one, you're going to take a deep breath in. You're going to breathe out Nigeria's troubles. So breathe it in well. Now breathe out all Nigeria's troubles. All right, now you can have your seats. Thank you. They say sitting is the new smoking. That sitting for long hours has the same cardiovascular risk as smoking. So it's quite important, that we stand up from time to time. So it's quite important. So we'll talk about chest pain. Recently, I don't know, over WhatsApp and in lots of the WhatsApp groups I'm in, there was a story shared by a former minister of this country. I don't know if people saw that story, of a patient that had chest pain, went to an emergency room in this hospital, in this country, in Abuja actually, and then was asked to go home, and later was brought in dead. Who remembers that story on WhatsApp? A lot of us. So when some of us saw that one, we were like, whoa. So this is one of the things that we've taught chest pain before, but I'm not sure we've taught it quite like this. If you look at your jotter, you will see a chest pain algorithm. A chest pain algorithm. So please go through it. If somebody can help me with the page number. A chest pain algorithm that tells you, well, at least for our local setup, what are the things you can do if somebody comes with a chest pain. So somebody comes with a chest pain first. The first thing you should do there, if anybody can find the page number so that other people can, page 15, 14, page 14. You see a chest pain algorithm. There are other algorithms on how to manage cholesterol. I don't know if what is going to talk about cholesterol a bit. There are algorithms on management of blood sugar, when a pacemaker is needed. The algorithms on what to do in certain situations. If a patient has tachycardia without a pulse, with a pulse, what you should do, cardiac arrest, step by step. So keep that jotter handy. You're going to use it a lot. And then there's an algorithm of how to read an ECG. You're going to use that jotter a lot. It's not just a jotter, it's a life pack. Okay. In the next 2 years, you will still need to reference it. Okay, so if you look at that, that particular one, you can see what will happen when somebody has I'm just waiting for my slides to be ready. You can see what will happen when somebody has chest pain. Okay? So the first thing you can see there, if I'm not mistaken, should be an ECG. Is that correct? Is that correct? ECG. Yes, so take a brief history and take an ECG. Please, an ECG must be done within 5 to 10 minutes. That is the global standard. Anybody coming with chest pain to your hospital, because you have come to ACS, you are an ACS alumni, you must have, so write to your an ACS alumni, you need to have an ECG. Be careful, make sure you have another job. But you need to have an ECG. Now, ECG should not be one that is locked up in the matron's office. They will now bring it out when it's time for accreditation. No. It's not the one that there's an ECG room far away. The patient comes at 2 a.m., the ECG technician has closed, is locked. ECGs must be there within reach. And you should be able to do an ECG within what? How much? 5 to 10 minutes. You should have it interpreted within 10 minutes. Now, I'm going to equip you to be able to interpret it, so don't worry, just be relaxed. So far, you can see, you can read an ECG, I assure you. And if you cannot read an ECG, we'll make a bet on something else. Okay? So within 5 to 10 minutes, you have an ECG read. What do you do next? It now depends. You will see different flow charts. So one of the next things you need to have in your hospital is the ability to check cardiac enzymes as much as possible. Codex has told us a lot of things for checking cardiac enzymes. One of their machines, they say can get us the troponin within 15 minutes. Now, if you don't have that, you should be able to have a center that you know that you can take a sample and send. And as we go through the chest pain algorithms and chest pain management, you will see how important troponin is in the diagnosis of chest pain. In the United States, up to 11.8%, as the last time I checked, of people with chest pain are wrongly discharged from the emergency room. So I know a lot of people, thank you. A lot of people were quick to say, these Nigerian hospitals. No. In the United States, up to 10%, 1 in 10, is wrongly sent home with an MI and actually comes back either dead or has to be rushed back with an MI in the ambulance. So, we're not doing badly. Don't say everything bad about Nigeria. Okay? So, what we just want to do now is to talk about chest pain and how we can get better at managing chest pain. The lecture brought by Cardio Care Hospital. Our vision in the Limi Hospital Group is to empower Africa through a healthcare ecosystem for training, research, and service delivery. That's why we are doing these trainings. Okay, we have been doing this for the past 6 years. Initially, it was a small room. We moved to the bigger room, then the much bigger room. People insisted that it must be done over 2 days. Then we did it over 2 days. During COVID, we did it online, yes, throughout, and it was very well attended. And then we had a physical BLS session, and we've continued. Last year, we were here, and we said that this role was much better than where we started. For those that know where we started, know that we have tried. All right, so cardio care. This is cardio care in the center there. There's also Limi Hospital, which is the main hospital, and the Limi Children's Hospital. Our pediatric cardiologists usually used to join us. Next year, by God's grace, we hope we can revive the annual Abuja Pediatric Symposium. And you will see our pediatricians in action at that time. And I hope you will all be here. All right, and that's cardio care. So the goal is to understand, detect, treat, and prevent complications. Let us understand. Let us be able to detect the condition promptly. Let us be able to treat. Let us be able to prevent. When a patient comes to your clinic or your hospital with chest pain, be 100% sure that at least you have done what you are supposed to do. That should be very good because you never know. It could be your brother, your mother, it could be anybody. They could call you from home now, from village. My papa is having chest pain. Okay? So that you'll not be among people that say, go and drink Panadol first. Okay. So this is case one. Case one. 24-year-old man, Mr. AJ, insidious, non-radiating left-sided chest pain that is waxing and waning. Is aggravated by body positions, by coughing, no significant relieving factors, query relief by paracetamol. All right, it has lasted for hours since onset, is moderate in severity. They had similar pain about 2 months ago after an upper respiratory tract infection. He's not a known hypertensive or diabetic, and no known elevation of lipids. He drinks socially. I don't know what that means, but he drinks socially. And occasionally smokes Igbo. This is a real life case. It's a real life case. It's not a hypothetical case. When he came into cardio care, he was rushed into cardio care ER with pulse of 106. Blood pressure was 146/76. Heart sounds were normal. Respiratory rate was 20. SpO2 was 98% in room air. So question one, what kind of chest pain is this? Yes, what kind of chest pain is this? We are going to our polls, cardiocare.ng/polls. If you're already there, cardiocare.ng/polls. What kind of chest pain is this? This man that had this young man, 24-year-old, left-sided, non-radiating. It has been there for some hours, moderate severity, no significant relieving factors, aggravated by body positions and coughing. What type of chest pain is this? Can we? No. What's happening? What's happening, Mr. Eno? It's showing the previous one. It's showing the previous. This is from the previous something. End it. Go back to the previous one and make sure it's closed. It's not there. Okay. Give me back my slides. Okay, fine. Good. So let's vote. What type of chest pain is this? This young man. Thank you, Mr. Eno. The number of I don't know is cut off. Can you hear me check what it is? Okay, so we have atypical chest pain, non-cardiac chest pain, typical chest pain, and I don't know, 9%. Please limit I don't know. Try, even if you fail, try. We are not voting Peter Obi, Atiku, or somebody. Just vote. Just vote. All right. So, what's happening? Sorry. We keep on trying this technology. Okay, so we typically evaluate chest pain by three criteria. Number one, is the chest pain left-sided? Number two, is it provoked by exertion? Number three, is it relieved? You see that also in your book. These three criteria. We say it is typical when all three are there. In this case, was it all three? No, definitely not. We say it is atypical when there are two. That is, there was presence of left-sided chest pain, or this is a WHO chest pain algorithm. And then, if there are at least two of them, were they up to two in this case? Hello? Remember the young man? It was relieved, there were no relieving factors, query paracetamol, and it was aggravated by turning and by coughing. So, the only thing that was there was one, that there was chest pain. It was not provoked by exertion, and it was not relieved by rest or nitroglycerin. Do you understand? 1/3 is what? Non-cardiac chest pain. So you can see that our answer was not quite correct. Non-cardiac chest pain. Mr. Eno, there's something wrong somewhere. Keep on bringing up that one. So when you are not taking the history from that man, some things that you must be there. Precordial, retrosternal. Find out. Where is it? The next thing, find out what are the aggravating factors. If this patient we talked about that came to this hospital, they should have done this one. They should have used that algorithm. They would have ended up in the correct, hopefully. Okay? Find out what are the relieving factors. How long was the pain? Okay? And find out, are there any associated factors? Diaphoresis, that is excessive sweating, dizziness. Are there any other cardiovascular risk factors? You must ask. Please and please ask. Also ask if they have been smoking anything. We had a 22-year-old that came into cardiac emergency room, rushed everything, then we looked at this boy. First of all, we saw from his hairstyle and the kind of guys, his profiling, Abi. We saw the kind of guys around him. Then his way his pupils were and the way he was just, initially, we had some people that started, what I said, no, this is not. We just gave diazepam and everything started coming back down. Fortunately, it came back 2 days ago, almost 2 days later, with almost the same thing. So the guy did not learn. Okay, so check for, especially in Abuja and Metropolitan, and find out if they are not taking something. Now, these characteristics are less likely to be cardiac. I'm not saying it is not cardiac, but it's less likely. When it is very sharp and pinpoint, like some of us now are already feeling chest pain, we're not sure whether we have chest pain or not. That kind of one is typically sharp, pinpoint, just at the left. That one is typically, it's not that it's not, but it's less likely. When it's directly under the breast, it's also less likely. When it lasts for a few seconds, it just comes, fiam, fiam, and goes. It's less likely. When it's lasting for days and the person is still going to work, eating, doing everything normal, is less likely. Do you understand? So it's more likely a person is having a heart attack and they are unable to do a lot of things. They are getting more diaphoretic, they are more breathless. The person comes, I've been having chest pain for 2 weeks. And he's gisting, he's on the phone, he has done everything, he slept. He said he even went jogging this morning. It's not that it cannot be, but it's less likely. If there's focal tenderness, you touch and you can feel pain, it's also less likely. If it's posture related, like this case, it's less likely. If there are no cardiovascular risk factors, it's not hypertensive, not diabetic, you've checked, the cholesterol is fine, it's less likely. So you now check if there are any of these things. Whenever you have 2 or more of these pretest risk factors, then we say that there's a high pretest probability. This patient has had a stroke before, high pretest probability. Family history of sudden cardiac death before the age of 40 or cardiac disease before the age of 40, high pretest. If they have only diabetes, high pretest. So diabetes is big. Okay? So if they have one or more of these, if they have only one, then we can say intermediate. If they have no risk factor, then they are low risk or no risk. So that is what we're going to use in this our chest pain algorithm. So you can open your chest pain algorithm on your manual, and look at it. This young man came in, and if you are not sure and you don't have an ECG, please refer. Heart attack, myocardial infarction is not something to play around. Please don't start doing MP and full blood counts. Please. Because sometimes you get the referral letter and you see MP results. That means you waited for the MP result to come out. Please. Chest pain. 12 ECGs within 10 minutes if there's ongoing chest pain. So this is kind of thing you should keep with the nurses that are taking vital signs in your hospitals. So all of you that are going here as ambassadors. When Nigeria is better, we are all better. We are not going anywhere. We stay here. We stay here. We don't go anywhere. So Nigeria must be better. That person that is checking vital signs should also ask if there is pain. Pain scale is a vital sign. Please don't forget, asking for pain is a vital sign. If they say they have chest pain, they should not go and join the queue. I'm waiting to see doctor, 20 people in front, and be fighting who is next. They should go straight and have an easy. So in this case now, this case we just discussed, where does this patient fall? Is it high, intermediate, or no risk factor? Yes, this young man, the 24-year-old. Anybody? Yes? Try now, try. The highest that will laugh. Try. The young man, you remember the young man? This young man, look at the case again. If you cannot remember, look at the case. Is this a high pretest probability, medium or moderate, or low or no risk pretest probability? Which one is it? Hello? No, there's nothing there. It's not hypertensive, not diabetic, no risk factor. So we didn't get any risk factor in this case. So automatically on our algorithm, he's going under this place of no risk. What do you do next after that? Check that your ECG. If the ECG is normal, follow this pathway. Exclude other non-cardiac causes. If the pain you are still unsure, please do troponin. Okay? Negative troponin, continue excluding other causes. So you have a normal ECG and you have negative troponin. If he has an abnormal ECG, despite having no risk, we have had patients come with myocardial infarction and, with no risk factor. Not just one vessel, 2 vessels blocked. So it doesn't exclude it. I want you to just know that. There's one man that came from NSCDC, slender. That guy is very slender, fit. I had to look at it again and again and again. So don't write it off and say the person is not fat and is not rich. It's not for rich fat people anymore. Okay? So abnormal ECG, please go straight to do troponins. After you troponin, then positive troponin, you must begin to treat like a myocardial infarction. Okay, I think you can see that. If it's other risk, the same way is the way you follow it. Please, you have this thing in your notebook, so you can refer to it again and again and again. Okay. So how do we now look at the ECG? What do we look at the ECG in terms of what to do? This is what the ECG is. And on the ECG, we are typically looking at the ST segment. And we can see the ST segment here. Can we see it very well? That's the ST segment. We typically look just one small box after this junction. So at this ST junction, just one small box. We'll use that to decide. When it is elevated, we say it's ST elevation. When it's depressed, we say ST depression. And sometimes it is okay, but there's a T wave inversion. All these are abnormalities that you must take note of. Hello? Is it hard? But it's up and down. Okay? It's like dollar. Up and down. Abi? Fine. Now, for us to be able to say that there is something, we must also make sure that it is not only in one lead. It must be in 2 or more contiguous leads. And you see the list there also in your workbook. The 2 leads must be from the same area. So, 2 people that are looking in this direction must all agree that what they are seeing is high. So, 1 AVL, V5, V6, 2, 3 AVF, V1, V2, V3, V4. If any 2 of them also confirm this, that is not normal. Don't send the patient home. Don't send the patient to clinic. Say, come back. We book you for 2 weeks' time. Okay, where people that are doing ECG can read the ECG, they will trap the person there. Sometimes people were going for normal surgery, just hernia surgery. They came to do ECG pre, and we caught them there. And then took them straight to the ICU from them. Please, you need a review immediately. You need a specialist input immediately. Okay? And then we'll go forward. So the case again. This is the case. We've gone through it. The next question is the history and clinical exam adequate? So let's go back to our polling site. Can we go back to our polling site? Don't worry, we don't know who picked what. So pick anything. And don't be afraid. We will not call you out. Why did you pick this one? Something wrong here. Wait to see. Okay. It's now. It was not connected before. Okay, let's have a slide. Still showing the wrong thing. Okay. Is the history and exam adequate? 73% said no. What is missing? Can somebody endeavor to tell us what's missing from the history and exam? 27% said the history and exam is adequate. Among the people that said no, can you be bold enough? Anybody bold enough to tell us who they voted for? Don't worry, we'll still give you contracts. It doesn't matter who you voted for. Yes? Anybody? What is missing? Everyone's afraid though. 77 people voted. So, shall I go ahead?
Okay, so now that we've determined it's non-cardiac pain, we need to go further into the history taking, like, you know, if there's fever and other things, associated symptoms. And also we need to do further examination, listening to the chest and all of it.
Good.
Attain the diagnosis.
Thank you very much. So, checking for chest wall tenderness, fever, malaise, are there other things are there any persistence? Is this the first time he has had it? Has he been having it before? All that will make for a more complete examination finding. Thank you very much. So, what's happening? So this was his ECG. We'll get the technology finally. All right, so this was the patient's ECG. For those that were here last year, is there any abnormality on this ECG? Or for those that are here now, any abnormality on the ECG? So let's start like we normally do. We check the the heart rate. What is the heart rate? 1, 2, 3, 4. 300 divided by 4, that's 75. That is okay. That is fine. We check the P wave. The P waves are upright here, and they appear before every QRS. That is fine. The PR interval is prolonged, so there's a first degree AV block. Right? We can see that. See where the P wave started from. This is where the QRS started from. It's more than one. See where the P wave started from? On this line. And then it's more than one big box. The P wave started on this line, and it's more than one big box. So there's a first degree AV block. Then we look at the QRS complex. It's narrow. Very good. Then we look at the T wave. Can we see T wave inversions there? Hello? Can we see the T wave here? It's upside down. The T wave is upside down here. It's upside down here. Don't worry, we'll soon do ECG. You will read ECG like anything. The thing is very easy. It's like reading ABC. We can see T wave inversion in one, and so this ECG is not completely normal. Okay, it's not completely normal. These were the results of this boy's investigation. ESR was 30. White blood cell count was this. Cholesterol was okay. Urea creatinine was this. Fasting blood sugar was that. Troponin was normal. Troponin was normal. ECG was not so bad. And stress ECG was negative. What do you think the final diagnosis is now? Yes? What do you think the final diagnosis is? Go to your algorithm. Follow your algorithm. Follow your algorithm. In the algorithm, he's on pathway 1. The ECG was relatively normal. Or he was on pathway 2. The ECG had abnormality, right? Hello? ECG had abnormality, T-wave inversion. So we did troponin. Troponin was negative. We did stress ECG. It was negative. So negative troponin means what? Exclude other causes. Can you see it's very simple to use? This patient now, if you allow the patient home, you can feel at least that Americans too will have missed it. All right, so what do we think the final diagnosis is? This is my slide though. What do you think the final diagnosis is? What's the final diagnosis? Yes, let's guess. Is it an MI? No. ECG was fine. Troponin was negative. Right? So not a myocardial infarction. Look at your algorithm. Follow your algorithm. Okay? It's unlikely to pulmonary embolism. And in this case, and there was no fever. The chest examination was fine. So we are looking more like a costochondritis. Let me tell you that most cases that come to the clinic, cold, young people without any risk factor, are most likely having musculoskeletal pain. And the chest pain was also less likely. So, we'll move on. I want to explain this again. Do we all understand why it is not a heart attack? Do you understand why it's not a heart attack? Negative ECG, negative enzymes could either be normal or could be an unstable angina. Negative ECG, negative enzymes. Think of it that this could be normal or it could be an unstable angina. Negative ECG, hello? Negative ECG, like this patient, and negative enzymes could be normal. Negative enzymes, in this case, and a positive ECG. This ECG is not quite positive because the patient did not quite have all the parameters. And so in that case, we say we are dealing with a costochondritis. Is there any question, please, so far? We are getting a little bit heavy. Is it getting a little bit complex? Getting a little bit complex? Not too complex. It's easy for you now. Not Nena. It's easy, Abby. Yes? So the chest pain nugget 1. Everybody must have an ECG within 5 to 10 minutes of arrival to the emergency room. Everybody. Please don't forget this. We've had a case. The woman has been coming over and over again. One chest pain here, one chest pain. We have done ECG, stress. It has been negative for 2 years. 1.5 years ago, she came again with chest pain. If not for our algorithm that everybody must have ECG, her ST elevation was now there. Finally, what she had prayed for. So it was there, inferior leads. I had to check again. We repeated it again. We checked all the ECGs we have been doing before. So don't say that this person has been crying wolf before, so they cannot have it again. Do we understand that? Every time somebody comes with chest pain, they must have an ECG. And it is a medical legal thing. That is what will save your license. And now you have this extra certificate that will stand against you, that somebody told you. Check the ECG. And if you can, check the cardiac enzymes. So please make sure you do that. I'm going to have to hurry up. In this case, we have this 56-year-old with worsening sharp chest pain, 2 days duration, aggravated by coughing and lying flat at night, relieved by sitting up, radiating to the left arm and back. There was nausea, there was fever, there was tachypnea. He's a known hypertensive. He's had stroke 3 years ago. This is a real life case. And then he has residual hemiplegia, does not smoke or take alcohol. He was rushed to cardio care, emergency room with an ambulance. Pulse was 112. Blood pressure was 146/76. Respiratory rate was high. SpO2 was 88%. Chest exam was normal. What kind of chest pain is this? Yes? What kind of chest pain is this? Remember, just 3 criteria. You can use your book. The expo is inside your notebook. What kind of chest pain is this? Can we try? Close the pole that she did that time. It may still be open. What kind of chest pain is this? It's still showing that one. What kind of chest pain is this case? We don't have time, we don't have time. What kind of chest pain is this? Is there left-sided chest pain and retrosternal? Yes, so that's 1/3. Is the chest pain, thank you. Is the chest pain aggravated by exertion? No. Can we see it aggravated by coughing or lying flat? Is it relieved by rest or by nitroglycerin? Hello? No. So by that criteria, this is non-cardiac chest pain. Okay, by that criteria, this is non-cardiac chest pain. However, we'll come to find out that this is actually not cardiac in terms of not myocardial infarction, but this turned out to be an acute pericarditis. An acute pericarditis. So why do we say acute pericarditis? It was aggravated by lying, relieved by sitting up. So nuggets, chest pain, aggravated by lying flat, and relieved by sitting up is more likely to be pericarditis. It could also happen in heart attack. So let somebody know, I say, no, it is not attack, be going. What must you do when somebody comes with chest pain again? What's the first thing you must do? ECG. So great. This was the ECG of the patient. And on this ECG, we can see something very fantastic. This is called a PR depression. The PR segment is low. Can we see that? Can we all see that? For those at the back, there are some screens by the side that you can also look at. We can see the PR segment is lower than the TP segment. So this is the TP segment, and this is the PR segment. It is low. So we have PR depression. We have some ST segment elevation all around. But if you look at this ST elevation, can we see this ST elevation here? It's like a saddle, like somebody can sit down on it. So that's what we call saddle shaped. This is a real life case that we managed about 6 months ago. Saddle shaped. So back on your algorithm, you will see under your manual. If you open your book now, you will see this slide again. You can see in number C, the ST segment is elevated, but it is saddle shaped. That is why we're looking more at pericarditis. The ST segment is elevated, but it is saddle shaped, but you cannot swear. What must you do next? ECG has ST elevation. What must you do next? Positive ECG must do next what? Troponin. Is this patient high risk, moderate risk, or intermediate risk? Very high risk. Why is he high risk? Hypertensive, and he has had a stroke. So it's very high risk. This patient should think of MI first. Even if the ECG is normal, you must still go ahead because it's very high risk. But we did the troponin. Where is troponin? Troponin was normal. Can we see the troponin? Normal. So remember our algorithm again. Negative enzyme, positive ECG, could still be MI, or it could be pericarditis. Why can it still be MI? If the patient came immediately it happened, the enzyme may not have risen. You must repeat that enzyme within 6 to 12 hours. So don't say that you did troponins now, it was negative, come and be going. Keep that person, especially those people at high risk, and repeat again within 6 to 12 hours. Yes, troponin is a costly test, but yes, it saves lives. Let them not use you for WhatsApp like they did. I felt very sad because that hospital is a very good hospital. I know the cardiologists there. They are fantastic people. Okay? Let them not use you to gain popularity, cheap popularity. Okay, so check again the troponin in 6 to 12 hours. Let the person say he doesn't want to do. So that when they are telling the story, they should also add it there. So check the enzyme in 6 to 12 hours and be sure you're not dealing with an MI. So final diagnosis was an MI. Okay? We did bed rests, NSAIDs, antibiotics. We gave oxygen, of course, it was breathless. And by day 4, he did not need oxygen again. ASR had reduced, white blood cell count had reduced. And this was the repeat ECG. Can we see repeat ECG? All those things are gone by day 4. And the patient went home and lived happily ever after. All right, so I'll have to go fast. You will get this in your slides that you receive. Please make sure that you register with your email and that your email is legible so that you can get the slides. If you do not put a good email, you may not get the slides. So we will send you all the slides. Don't worry, have them, share them, let people know the knowledge. But if you want to represent them, please give us credit. Okay? I will leave some of the higher stuff for later. So chest pain nugget 2. Cardiac enzymes are invaluable in the evaluation of chest pain. If you did not have cardiac enzyme in that case, you had ST elevation, what will you think? MI. You will start loading with tropidogrel, everything, jacking the person, and God help you, you gave tenecteplase. Okay? There's a company there, Healthline, that is deals with tenecteplase also. I think a generic version, very good. So it's expensive, but it's quite good. And God help you get them. So you must get cardiac enzyme. Please and please, we want you to become advocates. Get to your hospitals. ECG must be there. If you don't have cardiac enzyme, and Codex can give you a deal, I'm sure. Codex, are they there? They can give you a deal, I'm sure. But if you don't have that, make sure you have access to a hospital where you can take the blood sample and send. If you are within this environment, you can send to us. We can email you the results immediately within 15 minutes of getting the sample, so that you can take a decision, is this an MI or not? If we did not have the troponin in this case, it would have been difficult to differentiate. Okay, I will skip this case because of time, and then I will go to this last case. 65-year-old man presented with chest pain, retrosternal chest pain. It came 12 hours before presentation and 2 hours before presentation. It was aggravated by walking, and it was relieved by omeprazole and by resting. There was no radiation. He also had dizziness, palpitation, and feeling of weakness. No hypertension or DM. But when he went to the source of referral, the blood pressure was elevated, and they started him on amlodipine telmisartan. So who knows whether he was hypertensive before. But he said he has never known to be hypertensive. He does not smoke cigarettes or marijuana and does not drink alcohol. It was referred to cardio care for cardiac evaluation because they were not sure. They just said, okay, we don't know what this is. Go to cardio care, let us see. Pulse was 98. Blood pressure 135/84. Sorry, this SpO2 is wrong. SpO2 was normal. This is from the previous case. SpO2 was normal. So what kind of chest pain is this? What kind of chest pain is this? Be bold. Don't be afraid. Yes? Somebody say typical. Eh? Typical. Anybody else? Typical. Why do we atypical? This is our slide is showing something else. Showing from the previous presentation. So why do we say is atypical or typical? Let's look at it again. There's retrosternal chest pain. Criteria 1. Aggravated by exertion. Criteria 2, relief by omeprazole and rest. Criteria 3, typical chest pain. This is red flag number 1. Number 2, he has an elevated blood pressure. Somebody asked a question about one-time elevation of blood pressure, and I told you it's very unlikely. The blood pressure is elevated, and he had to be given 2 drugs from where he was referred from. That tells you the patient is likely hypertensive. Okay? I hope this helps. So, hypertension is there. That moves him to, is that moderate risk, high risk, or low risk? Moderate. One risk factor is moderate, not so. Does he have any other risk factor? Just that. One risk factor, hypertension, Abi. So moderate. What should we do next? ECG. Look at his ECG. What can we see there? What can we see there? Anybody? We can see that there's ST elevation here. V3 and V4. V2 small, V3, V4. Can we see that? You can see the T wave upside down. Can we see the T wave that's upside down? T wave is upside down. From V1, V2, V3, V4, T wave is upside down. So we have an abnormal ECG. So follow your algorithm. Go back to your algorithm, please. Go back to your algorithm. One risk factor with positive ECG. What do you do next? Troponin. Not so? So let's go to our troponin. See the troponin. 11.7. What is the normal troponin? 0.3. His own is not 1 time high. It's not 10 times high. 10 times the upper limit will have been 3. 20 times will be 6. 30 times will be 9. It's almost 40 times the upper limit. And the person was just referred. He came at his own time. He did not even come immediately. They said I should just go. So he came for evaluation, and this is what we found. Hello? So this is a case that can easily be missed. But if you follow the algorithm, every time, follow the algorithm. Just follow it. It's there with you. You can keep it. Keep it on your phone. If you join the WhatsApp group, you can see it on this thing. We also put the soft copy so you can have it on your phone handy anytime you want to check. Check it again and again and again. So, what is the final diagnosis in this case? Yeah. What is the final diagnosis in this case? Hello? Say it out. You are ACS graduates. Yes. Sign your name, fellow ACS. Yes, what is it? Pulmonary embolism? Acute MI. Correct. So we have an acute myocardial infarction. Myocardial infarction, you need an abnormal ECG, you need elevated enzymes, and you need a setting of acute ischemia. What is the setting of acute ischemia? Chest pain. Somebody coming with chest pain. So sometimes there's a case I had to skip. A 16-year-old came. She had severely elevated enzymes, but no chest pain. She's been having that for 2 weeks. That was not acute myocardial infarction because there was no setting. We gave her medications. We started. 2 weeks later, it was still elevated. I don't know whether Dr. Lekon remembers that case. 3 weeks later, it was still elevated. It was a myocarditis. So, in that case, a myocarditis is damaging a virus is damaging the heart muscle and raising the enzymes. No chest pain. She just came with difficulty in breathing. Exertional dyspnea. Anytime she walks small, she gets tired. So those are people that will develop heart failure in the future. And people will say, I am dilated cardiomyopathy. So she developed that. She went to the US. They did all the tests, everything. They arrived at the same diagnosis we arrived at. Okay? So it's quite important. So if you have elevated troponins, if there is no acute ischemia, we call that acute myocardial injury. And that can happen in heart failure or myocarditis. If there is acute ischemia, then we say acute MI. And you know the different types of MI. If the troponin level is elevated and stable, it could be chronic myocardial injury, like this young girl I talked about. It remained high for almost 2 months, despite steroids, despite non-steroidal agents, it remained high. We call that chronic myocardial injury. So in this case, remember, I'm rounding up. Chest pain is the most common presentation of MI, but not everyone with heart attack has chest pain. Please remember, some people don't have chest pain. They just come with heart failure. They come with pulmonary edema. There are just crepitations everywhere. They come with arrhythmias. They come with silent MI or sudden cardiac death or cardiac arrest. Anybody that has cardiac arrest must have an ECG. They had cardiac, you were trying to do hernia, you were trying to do appendectomy. They had cardiac arrest, you resuscitated them. Please have a full evaluation for them. You don't know what, that could have been a presentation of MI. Some of the patients that had diabetes presented for the first time with an MI. They did not know they had diabetes before. Now, the examination is typically normal. The only thing you might find is tachycardia or hypotension. So frequently, examination is normal. Like this case, even SpO2 was normal. And we showed you about the ECG. The SC segment is elevated or just like here in STEMI. Okay? I'll move fast now. So how do we treat? How do we treat MI? The MI has landed in your doorstep in the middle of the night. Where is that, my senior colleague? In the middle of the night, you have nobody there. You are 30 kilometers from an ICU. What do? In the middle of the night, please remember that time is muscle. The more time you waste, the more amount of heart muscle is dying. And the worse it will be for that patient. So you must start treating early. You must know what to do, and I will tell you what to do. So typically, patients should try and get early response and reperfusion therapy. Get to a cath lab as soon as possible. If you are within reach of a cath lab, like cardio care, we're not far from here, and some of us can have time, we can go to cardio care. Get to a cath lab so that we can get to the heart and open up the blood vessel and put a stent. Sometimes people have come. I think the earliest we have had somebody is 12 hours, but most people come 3 days, which is quite late. That's one of the reasons we say let us teach about this. Okay? But after 12 hours, it becomes very difficult. We have to stabilize first before we go in because there's a lot of problem. Before 12 hours, you have a lot you can do to save that heart. And these are the goals of treatment. Time is muscle. Restore coronary blood flow as soon as possible. Treat any complications and reduce them. Reduce morbidity and mortality. Patients die. They can be talking to you perfectly fine, and the next minute they're having a cardiac arrest. Never assume that an MI is normal. There's a place I went to teach after I taught. The patient, I think, was a Pakistani. He came only with epigastric pain. Looking like ulcer. But I had taught somewhere, and somebody did an ECG immediately, and he had the elevation of the MI. And they referred on time. I really want to appreciate that hospital. I can't remember the name. I think they are here. Yes, thank you. They raised their hand. They referred on time, and we rushed into the cath lab. Those people, they went back to Pakistan after we put a stent, and they bought me something. I don't know what it is. It looked like I don't know. And one funny coffee. I've never drank it. But it was very nice. They were very happy. So the patient presented only with epigastric pain that has some small relation to the chest. That is why we said everybody. We've had several patients with query ulcer. In fact, the last patient I treated as an SR before I left UCH, that was about 8-9 years ago, was a professor. He was doing the exam. I don't know who swore for him during the exam. He was doing the exam and he kept on complaining of, he was actually a former VC, complaining of epigastric pain. They brought Gaviscon, they brought, after a while, he just said no, they should take him to the A&E. He had to stop the exam, and that's the last patient I remember. I gave the patient Tenecte, please, because we rushed the patient to the A&E. It was picked immediately. We took to the ICU and we gave thrombolysis and opened up. The next day, the ECG was back down. Fantastic, and then he could now go back. So you must recognize it. Everybody here, nobody should miss it. Nobody should miss it, and we will show you that you can read the ECG very well. So immediately do a 12-lead ECG. You are. Don't say that patient cannot afford it. You must have an ECG. Hello? Hello? No shortcuts. You must have an ECG. Everybody, every nurse, every doctor must know how to do an ECG. If you don't know how to do an ECG or to, please, go and know. Maybe I should tell them this year. They used to come for this. Maybe I should tell them we should be checking that one when we are renewing license. You must not do an ECG. Check it. Wherever you are, do the ECG. Now, you know the good thing about an ECG machine, I had hoped that we could get a vendor that could sell ECG machines. An ECG machine, is, especially the ones that are computer-based, is cheap. The only consumable you may use is the gel and maybe the paper. That is all. So if a patient cannot pay, leave it to God. The other people that will pay, do you understand how cheap ECG is? As it doesn't cost more than that gel and the paper. And if it's computer based, you don't even have to print. You can look at it, please. Or at least if you put your patient monitor, a lot of our patient monitors in our hospitals, but we're not using them. Put it there and at least look at it, but you need a full 12-lead ECG. Okay? Now, once you make the diagnosis like we have done now, start ECG monitoring, insert a cannula, get specialist inputs immediately. Now, join a WhatsApp group so that you can get advice. You can put it up. There are about 6 cardiologists in cardio care. One of us will be awake, hopefully. All of us should not be sleeping at the same time. One of us will be awake and can at least assist you. So join the WhatsApp group. You can put the ECG there if you are not sure, but I assure you should be able to read it. Do your enzymes and then then start with your aspirin and clopidogrel, unless it's contraindicated. Okay? You can call cardio care within, but make sure you follow this. This is what you must do. First, medical management. Everybody that has an MI must have. Please don't forget this. I want you to write this down. Keep this in your mind. It's not meant to be forgotten. If you don't remember anything in this ACS, please remember this one. Nobody should have sudden cardiac death. Nobody should die because of MI. At least nobody that sees anybody here. And you know what to do that you can remember. When we send in the slides, catch, if you are the medical director, good for you. Catch your staff and start teaching. If you're not the medical director, call your nurse. If you're the nurse manager or the matron, call them, teach. Anytime you teach, you get better. I've taught this thing at least 30 times. The more I teach, the more I get better. That's why I know it a lot. Abi? So catch some people and teach. That's how I started teaching ECG. The medical students that were in my unit, I saw somebody that was my medical student. The medical student in my unit, they really enjoyed it. Because when I read, I catch them, whether they want to hear or not. Till 11 p.m., we'll be teaching. Okay? So it was good for me. So catch somebody. So pain relief, oxygen. Don't give oxygen if the SpO2 is normal. It worsens the outcome. Hello? Don't say he's breathing. Check the SpO2. If it's normal, don't give oxygen. So SpO2 less than 94, 94 and below, you should be consider 93 and below, you should consider giving. Give nitrates. Okay? If you know what to do, give nitrates, except the patient has inferior MI or the blood pressure is low. Give antiplatelets. In antiplatelets, you want to give aspirin. Don't say the patient has ulcer. Hello? Ulcer is not a contraindication to aspirin in MI. Can we say it together? Ulcer is not a contraindication to aspirin in MI. Let them have their ulcer after. But let them be alive. If you like, you can give omeprazole or gas afterwards. That aspirin, want them to chew it so that it works fast. We typically like to give, 300 milligrams, that is 4 tablets of the baby aspirin, 4 tablets. That baby aspirin, you give 300 milligrams, they should chew it. The clopidogrel too, 4 tablets, typically. Once you are sure of diagnosis, if you are not sure, please don't give. Check so that you don't worsen an aortic dissection. Or once you are sure of diagnosis, please give. Then beta blockers, anticoagulation, and get ICU and specialist care. Okay? In every town, there is typically a cardiologist not far. There's an FMC near, there's something, at least Nigeria has tried to an extent. And even then, you have access to us through the WhatsApp groups. So we can assist you wherever you are by the grace of God. One patient is alive, we can talk about other things. Okay? This can go a long way to save a patient's life. Just these single things. Even if the patient does not have money for any other thing, this alone will alter the patient's mortality benefit. Now, early reperfusion. If that patient is presenting within 0 to 12 hours, you need to consider immediate reperfusion. Either you get them to a cath lab, which is the best standard, so you can get them to cardio care as soon as possible. If you are in Lagos, you can get them to any of the centers that has a cath lab there as soon as possible. That is the preferred one. If you cannot get them, then thrombolysis should be done. Alteplase is there. I think Boringa is going to join us. Are Boringa here yet? Alteplase is there. And then tenecteplase is there. Boringa also has tenecteplase and Healthline that is at the back. Please try and get one in your vicinity. We typically have Alteplase and tenecteplase in our facility in case any hospital needs in the whole of Abuja. It's very expensive. So people don't like to stock it because if it expires, it's about 400 or 500,000 or 300,000, I can't remember. If it expires on your hand, you know what it means. Okay, so, but we have one that at least anybody can come and pick and use, and then, you know, when it is. So because we have more patients with MIs. So you can use this one in the interim pending. If the patient cannot afford it, the house usher, the patient cannot afford it at all, then consider streptokinase. I don't like streptokinase. It has so many problems. I've had a terrible issue with it. It can cause severe hypotension, can cause severe reactions and all of that. So the patient can truly not afford it, or you have no access to the proper drugs. Outer place should be around 600,000 or 500,000 for the vial. This other one, if it is a generic one, is about maybe 300 or 400,000, I don't know. They can tell you at the back. You can meet them. Now, if you get to the cath lab, we put in a catheter, we do the angio, we find out where it's blocked, and we put in a stent. And then we open this up. Now, it is late presentation. They've come after 1 day, 2 days. Still, medical management, start this immediately. It's 3 days later, they are still complaining. You may not be able to give thrombolysis again. After 12 hours, you cannot give thrombolysis again. The risk outweighs the benefit. You will get more bleeding, stroke. If you are going to give thrombolysis, please make sure you get specialist inputs as much as possible, and thank God for phones, so that you don't run into trouble. Please and please. Even when we're giving it, it's not everybody that used to give it. Even among us SRs, they used to call, there are bigger SRs. You know, you call them to say, oh God, I won't give thrombolysis. We'll come and stand with you. Okay, so this is what you'll do. So if it is late presentation, angiography and PCI may still be done, but they may need to be stabilized first. But you must still go ahead with medical management, which happens for all of them. Then follow up, beta blockers, AC inhibitors. Sometimes there's nothing we can do. In MI, 50% of patients don't get to the hospital abroad. That is the people that have 911. Chest pain, 911, 50% will not get there. Not our own, no. 50% don't get there. So you can see how high. Of those that get there, the hospital mortality is as much as 25 to 38% in a lot of centers. With everything, insurance, cap, everything is there. So you can see it's not something you should joke around with. Sometimes they are there, somebody is saying they have pneumonia, they have some chest pain, they're not getting better. Please and please. Or also they're not getting better, you have given, please do your ECG, check your enzymes. It's better for the patient to spend money unnecessarily than for the patient to spend money on funeral. Okay? So this is very important. I will have to stop now. Again, Monash, ABC, morphine for the pain, oxygen if needed, nitrates. Don't give if there's inferior MI or hypertension. Also, before you give nitrates, ask, have you used Viagra recently? Don't be afraid to ask. Please, there are so many things that they are selling in the pharmacies these days. Ask, call the person, just ask everybody, please wait. You know, sometimes the whole family is there. Don't ask in front of the son, please. Just ask them to wait outside. Okay, how far, anything. You know, please ask. If you give the nitrates and the patient has had sildenafil or tadalafil before then, you will have hypotension that you cannot come out of. The blood pressure will slam down. You are on your own. So please ask before you give it. Then your aspirin and clopidogrel. If you have other ones, prasugrel is better, but it's very difficult to find. Statins and heparin. Please give them. The statin we are giving is a very high dose statin. If you are giving atorvastatin, that is a Lipitor brand for Novartis, is 80 milligrams we give, 80. If you are giving rosuvastatin, is 40 milligrams we give for acute coronary syndrome. Okay? And then you will still have to give some heparin or clopidogrel. It typically helps. This is what you need to do first before referring the patient. Get specialist input as soon as possible. MI kills. Okay, so I will show you what it is. This is cardiocare. I will show you how we do the procedure. This is cardiocare, where we do the procedure. That's us in the cath lab. I'm doing a case recently. And this is us with some residents and consultants teaching. So we just do that. You can see how we puncture the vessel. Very simple. You can do it, Abi. It's like doing a venopuncture. Then, after we do that, we pass our catheter in. We put a sheet into that femoral artery. We pass our catheter in. The patient is awake. There is no anesthesia. The patient is awake throughout. We just do local anesthesia around where we give the injection. Then we give a dye to see where the blockage is, like this. And then we give a dye also to see both the left and the right side. In this case, this was a 42-year-old computer operator. You can see where the narrowing is. Can we all see that? It's very clear. And so we pass a wire across the narrowing. That is us passing the wire. It's a very complex procedure. It's not very easy, but it's very, it's relatively easy. We pass the wire, then we pass a balloon across to open up the blockage a bit. After that, that is to prepare the lesion. Then we come over with a stent. The stent is a wire mesh. It is typically drug-eluting. There are drugs embedded on it. So it now stays there and keeps it open. This stent is there for life. We're not going to take it out later. This is how we inflate the stent. It's not a syringe we use, but it's a measured atmospheric pressure. Okay, so you can see us inflating the stent. Can we see the balloon there? We're inflating the stent to open up that blood supply. Then we can check after we are done. And you can see the narrowing is gone. Can we see that? The blood supply is gone. MI has ended. Okay? Typically, patient 24, 48 hours, they can go home when we watch complications and all of that. So you can see that that is how it is done. This is the ideal. If you can get the patient to do this within 30 minutes, best. 1 hour, best. 12 hours, best. But if you cannot, you may start some thrombolysis initially if you are far away and you are sure of diagnosis before we do that. This is another case. We've done over 500 cases of different interventions in cardio care successfully by the grace of God. Okay? That patient I talked about, remember the patient we talked about, the story we've just given, and his ECG, he had 85 to 90% left main stenosis and 85% mid-segment LAD stenosis. He had 2 stents, procedure well tolerated. He was transferred to ICU, and then he was later discharged. This was the ECG representation. You remember? Can we all see that? With the S elevation and the T wave inversion. This was the ECG 4 days after. Can we see the ECG after? The heart is coming back and it's still telling us thank you. And he lived happily ever after. Thank you very much. I would like to take any questions if there are. I would like to take any questions if there are. We've had to compress a lot of stuff in a short time. So please, do you have any questions? I cannot go through everything, but you get a lot of the slides. You get all the slides, and you can watch the video again. We have also webinars that we have done on chest pain and MI on our YouTube channel. You can go and watch them, rewatch them again, and we can take it from there. Any questions? I think we can take 2 questions quickly. 2 burning questions on chest pain. Yes, sir.
Thank you, Dr. Iseko, for that beautiful presentation. Please, what is the difference between acute myocardial infarction and ischemic heart disease?
Okay. Thank you very much. Okay, so I had a slide for that, but I could not go through it. So ischemic heart disease is the condition that is the umbrella condition. Every single condition whereby there's reduced blood supply to the heart muscle is called ischemic heart disease. Every time there's reduced blood supply to the heart muscle, ischemic heart disease. This comprises from what we call an acute coronary syndrome to a chronic coronary syndrome. Chronic coronary syndrome typically consists of what we call chronic stable angina. The patient has chest pain, he stops. He does exercise, he relaxes, he gets better. My wife went to do her hair in the hair salon, and somebody was complaining that anytime she climbs up the staircase, she has chest pain. But when she was asking the other people in the hairdressing salon, somebody said, she knows that thing, that you need to be drinking Coke. Real life story, that you need to be drinking Coke more and more. I don't know what's happened to that woman. Okay? So they say you need to be drinking Coke, that you just drink Coke. Anytime you come, just drink Coke. It will go down. Okay, so that's chronic coronary syndrome. It used to be called chronic stable angina. Now it's renamed chronic coronary syndrome. Now, under the acute coronary syndromes, we have acute myocardial infarction, which may be ST elevation and non-ST elevation. And then we have unstable angina. So those are the ones under the acute coronary syndrome. So the umbrella is ischemic heart disease. We have acute coronary syndromes, and we have chronic coronary syndromes. Chronic coronary syndromes are typically chronic stable angina. They are fine otherwise. Only that when they walk, when they have sexual activity, when they change a tire, when they do something, they have chest pain. When they rest, it goes away. They say it's nothing. Almost all the patients that we see with MI, tell us that they've had that for over 2 years before. They thought it was nothing. Somebody said you should drink paracetamol, or different stories, or they have been drinking omeprazole. It just that it's not working again. Now the acute coronary syndrome, MI, or unstable angina. And the MI could be ST elevation or non-ST elevation. How do we differentiate acute ST elevation MI, non-ST elevation MI, and unstable angina? How do we differentiate them? By those simple two tests. What are the two tests? ECG and troponin. In unstable angina, you typically have, you may have an ECG that is neither here nor there, not characteristic diagnostic, and the enzymes are negative. Once the enzymes are positive, you are dealing with acute MI. If there is ST elevation, we call it ST elevation MI. And if there is no ST elevation, we call it non-ST elevation MI. Okay? So that is the difference. I hope that helps. Yes, somebody there. Please ask any question that you have, either from this or from any area of cardiovascular medicine.
Thank you, sir.
Or medicine at all.
Sir, please, I would like to ask for a patient that comes in with atypical chest pain, atypical or a cardiac pain, and the ECG is negative. Do you still need to do troponin? Do you need to assay for the enzymes?
Okay, thank you very much. Okay, so let's go back to our algorithm. Can we go back to our algorithm? Atypical chest pain. What do? The first thing is what? You find out the risk. What is the risk level of the patient? If the patient's risk level is high, you must do troponin. If the patient's risk level is intermediate, then you can leave to your clinical judgment. If the patient's risk level is low or no, then it depends. You can now manage. So if you have atypical chest pain or non-cardiac chest pain, doesn't mean it's not MIO. It just helps you to know how to help. Now, if you now do that and the ECG is normal, atypical chest pain and has low risk, use your algorithm, low risk, normal ECG, you should do what? Exclude other causes. However, remember what we said. If the patient is still having ongoing chest pain, what should you do? Repeat within 6 to 12 hours that troponin again. I mean, either the ECG or whatever. So you may consider doing the troponin. So that is the place where we say either or. If the person has 24-year-old, no hypertension, no diabetes, ECG is normal, no previous risk factor, no risk factor, atypical chest pain, then you may or may not do troponin. In our center, we do troponin for everybody. Okay? So if there's now financial constraints, insurance say they're not going to give you approval, then you can be arguing like that. I hope that helps. That helps. Okay. Please.
Thank you for the presentation, Chief. My question is regarding the use of aspirin and clopidogrel. So there's been this conflicting thing we've been seeing around in practice. So people tell you that once you're using the aspirin, then there's no use to use the clopidogrel. And some others say use clopidogrel if you don't want to use aspirin. So I don't know if you can clarify, is this something that we have to use both, or one is enough, or either is enough? Thank you.
Thank you very much for that question. Please ask questions, because I'm sure when you ask the question, it's in other people's mind. Okay, so in terms of aspirin or clopidogrel use, number one, all patients with hypertension should not be on aspirin. So sometimes we see everybody because of Zebudiah's advert. Abi? Remember that Zebudiah advert? So doctors even are following that Zebudiah advert. Not everybody. Remember the algorithm that Dr. Oladekon showed, and many of those people with higher risk that you are thinking should have. I think Dr. Officer will shed some more light on that. Now, when you now need to put an antiplatelet, yes, a lot of times we typically try to use either aspirin or clopidogrel. However, there are cases when you have to use both of them together. MI is one of them. Anytime you have an MI, you need to use both of them together, because they work in two different pathways to block platelet activation. Okay? So, and aggregation. So, for MI is one of them. Another reason why you use both of them is if the patient has had a stent. When we put a stent in the patient, they need to be on dual antiplatelets for at least 6 months to 1 year. So they'll be on dual antiplatelet for 6 months to 1 year. In those patients, those are the ones that will use dual antiplatelets. Sometimes some people still use dual antiplatelets if the patient has peripheral vascular disease and they are unable to get peripheral angio. But I advise you, get a peripheral angiography and find out what the problem is. So if you come to our lab, we will do the peripheral angio, and if there's a problem, we can, because it does not prevent, it does not all totally stop the problems. Okay, so this is where some of the things we need to know about. Okay, I hope that helps. Yes.
Thank you very much for your presentation. Regarding the management, the medical management for the pain relief, I recall that there were different schools of thoughts regarding the use of morphine. Some supported its use, whereas others were against it. May I please know, can you please share more knowledge on this? Why is it that morphine was contraindicated, or some physicians said we should not use it for MI? Thank you.
Okay, I don't know those physicians, Sha. Do you know them? But I would say, do you know them? So I don't know that school of thought. That school, what's the word in school? I'm joking. All right, fine. So why do we prefer morphine for MI? So I'm not aware of any research. I'm a scientist. I'm not aware of any research that says morphine should not be used in MI. I'm not aware. Okay, so why do we prefer MI? Morphine, for MI. You can use pentazocine, Abi. You can use other ones. But why do we prefer that one in particular? The reason is that besides pain killing, it reduces anxiety. So that reduction in anxiety helps to reduce the heart rate, reduces sympathetic outflow, and that helps in outcome. Number two, morphine also has some vasodilatory effects and also helps pulmonary blood flow. So all of that helps to, so that's why we prefer morphine. Where I trained, if you don't give morphine, we don't give anything. Now, if you give NSAID, you are going to worsen it. Why? NSAIDs are going to cause constriction of afferent arteriole and increase intraglomerular pressure. Okay? That will be a problem. So that could worsen your blood pressure control. That could worsen outcomes. NSAIDs will also cause retention of fluid and worsen cardiac function. So we don't like to use NSAIDs. If you don't have morphine, then you can think of the other ones. So the typical thing is to give an antiemetic and then give, morphine is typically preferred. Gives all of those. Now, there are some people that do not tolerate morphine for one reason or the other. Those are the ones that you can choose. So I don't know if anything has come out about morphine. I'm not aware. Okay, so all the panel in front said they've not. So we don't do that. Morphine is the preferred one. Now, morphine is a controlled substance, so it's difficult to get. And in your hospital, it's probably under lock and key, just like it is in ours. Okay, and one of them is very expensive, as in extreme, either the syrup or the IV. The syrup is very expensive, very, very expensive. So I think you can give the IV, but make sure you give an antiemetic. Otherwise, the patient will start vomiting in front of you. So typically, we give antiemetic before, and then you give your morphine. And it typically helps. It helps outcomes. That is why it's part of the standard guidelines. Okay, are there any other questions? Any other burning questions on chest pain? So right now, we have established that anybody with chest pain will know exactly what to do. If it is an MI, we know what to do. We know how to differentiate one form of chest pain or the other. And by God's grace, we should not send away a patient that is well otherwise. Thank you very much, and have a lovely rest of conference.
Thank you very much. That was an amazing presentation on chest pain. And believe me, he has whet our appetite to learn about ECG. You can't really make a diagnosis of chest pain without the ECG, from what he has said. And every chest pain is not also pain. Yes, so if you want to learn about the ECG, about what are they supposed to do? Yeah.
Oh, yes, come back tomorrow.
Yeah.
Actually, full disclosure, before I joined